In this video, I want to share how I like to fix sciatica without stretching. Now, I will say that I'm not totally against stretching. What I usually don't like is when it's only stretching. And the reason for that is because I like to look at it as when a patient comes in and they're dealing with sciatica or sciatica type symptoms, they're coming in with a certain pattern, and that pattern and or position that they're in creates what they're feeling. So I like to look at it as I want to disrupt and then change the current pattern. And to me, when we just do hamstring stretches and piriformis stretches, it doesn't change the pattern. And if it doesn't change the pattern, it's really hard to get long-term results. So I want to go over my mindset and framework as to how I like to really provide long-term relief for patients dealing with sciatica. So there are two things that I think will really help improve your awareness of a certain pattern that your patients may be in. And those two things are, first, being able to visualize the biomechanics of the pelvis and what creates the compression in the first place. And then number two, recognizing certain asymmetries during your lower extremity assessment. So let's first jump into the biomechanics of the pelvis. So with the pelvis, we need to first ask ourselves, why are they dealing with it? And what does it look like from an anatomical standpoint? A lot of times we have asymmetries, and these asymmetries create compression in one part of the pelvis and expansion in the other. An easier way to look at it is think of it as a locked versus unlocked door. When someone has a biased position where they're slightly turning to the right or left, it's going to create a response as far as the locked or unlocked door. If I turn to the right, what I want you to really look at is this outlet here where my fingers are. If I turn to the right, you can see how this right posterior outlet opens up, aka this is being open door, and this left side actually compresses and is more of a locked door. When someone has this type of pattern, they're typically going to present with left sciatica type symptoms. Why? Because that locked door is jamming that sciatic nerve. And so we get the compression based off the position we're in that then creates the person's pain and experience that they're feeling. If we turn this the other way, just recognize that it's the complete opposite, right? We have compression of this right posterior outlet and we have expansion on this left. So I think it's helpful to think of the locked versus unlocked door scenario so you can just start to visualize how this person is patterned and or positioned. Or another way of thinking of it is, which way are they turning? When someone is turning towards the right, they're usually going to have the locked door on the left, and that's going to create the sciatica type symptoms. If it's someone that's turning towards the left, they're going to have the opposite, opening on the left side and compression on the right posterior outlet. So that's great to be able to visualize it, but how do we objectively measure it? Well, that's where your lower extremity assessment comes in. And what I want to do is go over an example where someone is turning to the right, and if you are dealing with someone that is turning more towards the left, the measurements are just going to be in opposition. So when someone is turned to the right, we would expect them to experience more left-sided symptoms. Why? Well, again, if I turn this around, if I turn to the right, we see opening on that right posterior outlet and more compression and closing down, or a locked door on the left outlet. And so that's what usually creates that sciatica type symptoms. Besides that, what happens from an assessment standpoint? Well, when we're turned to this right side, the pelvis on the right's in more internal rotation and the left side's more external rotation. So what does this mean? This means that as we are doing our assessment, the right side usually has more internal rotation. It's usually going to have a greater or more range of motion to their straight leg raise. Also going to have an easier time moving through hip adduction. And so again, that means on the left side, we're going to have greater external rotation measures, usually greater hip flexion, hip external rotation, hip abduction. And again, if it's the opposite you're dealing with, then you will just see the opposite as far as IR on the left and ER on the right. So we now understand the biomechanics of the pelvis and what to look for during our assessment. Now the next question is, what do we do for our treatment? We already said that we don't necessarily want to just stretch them. And hopefully by now you understand that if someone's in a position that's more asymmetrical and turned, when we just start stretching structures, we may get the extremity more mobile, but we're not creating a change, creating a pattern change throughout the pelvis. That pattern change is what's going to really help drive long-term results. So in order to do that, we need to work on hip shifting activities. And here's the thing, when you do it successfully, the structures that are tight are going through a more of a dynamic stretch. So not only are we stretching them dynamically, but we are training muscles how to turn the pelvis. And every time we turn the pelvis, we start to open up an area that is closed down, aka we're opening the unlocked door, creating more space where that sciatic nerve is getting compressed. 3 exercises we can do are just different variations of hip shift. Yes, there's way more exercises out there, but this is a great way to start, especially if someone is really dealing with a lot of symptoms. So the first one is just a side-lying hip shift. Side-lying is great because it really allows the patient to be able to feel that movement. So what you're going to want to do is set up with the feet on the wall. Super important that the feet are on the wall, so that way you create more of a closed kinetic chain exercise. And so the pelvis becomes more of that key mover compared to the femur, right? So feet on the wall, foam roller in between the feet, so that way we have more of just a neutral position throughout the foot. We have a ball between the knees, and then we want to make sure that we're in a stacked position with our head nice and relaxed. From here, we're just going to go through a slight posterior tilt just to get more of a neutral position. We don't need to be completely rounded. We're going to cue our patient to press into the wall or get grounded and push into that through mostly their midfoot into that wall. We're going to drive the knee down, and then all we're looking to do is to place the hand here, and we're just trying to get them comfortable with pulling back, feeling a slight stretch in the glute, feeling a little inner thigh while maintaining contact on the wall. What is this doing? Well, the movement is opening and stretching that posterior outlet that's usually compressed. The inner thigh, the glutes, and the hamstring we're feeling are helping to provide more internal rotation strategies. Remember, when we start to draw back, the pelvis is going into more internal rotation. That's good. That opens up that posterior outlet. So again, a really easy exercise that can help someone get more familiar with how to pull back and doing it in a way that's not arching through their back, right? And that's why I like to keep the hand here. We don't want them to feel rotation like a clock, like going clockwise or counterclockwise. We want them to feel that motion going straight back while trying to maintain the glute, the hamstring, and the inner thigh. So now all we're doing is going from the ground to standing. So just a standing hip shift, no extra weight, just a little bit more challenging from a standing perspective, but we're still gonna have the ball between the knees, and all we're gonna do is hinge back and use the dumbbell rack to just stay a little bit more open and keep the rib cage back. And then from here, all we're doing is trying to find those same muscles, the glute, the hamstring, the inner thigh. And we do that, we find the glute by pushing into the ground. We have the inner thigh by pushing into the ball. And then as we pull back, we're trying to really feel that glute and hamstring. So again, all we're doing is pulling back, and you should see my right knee going in front of the left, and I feel a stretch on this left side, and then we come back. Again, dynamic stretch, but more so training the patient how to turn the pelvis with the right muscles. We want to consciously do this so then we can subconsciously start to be able to do this when we walk and when we're not thinking about what we need to do as far as our pelvic mechanics. That's how we really change a pattern. So again, standing hip shift, shifting towards the symptomatic side so we can open up this posterior outlet. Our final exercise is a split stance deadlift. The overall goal here is to load the movement. So we're still going through the same mechanics, looking for the same muscles, but now we're just adding strength and really starting to train that patient how to obtain strength, obtain stability, and obtain mobility to turn the pelvis. So same thing with a ball. You can add a slant board to go to a toes elevated position if you want. We're going to go staggered stance. And so the right foot is in front, the left foot is in back. Again, symptomatic side is in the back. And then we are reaching this kettlebell towards the left foot. I like to bring the left hand and bring it back. So we're reaching that right knee forward as I draw back. We're not going into the back. This is all a hinging motion, but the knee goes forward. The left knee really stays where it is. The pelvis is shifting back, right? A lot of times people straighten out the left knee. We're not trying to straighten out the left knee. We're turning the pelvis so that knee stays pretty constant. And when we go down, I keep that knee pushing into that ball. That's going to help open up that posterior outlet, and then we would repeat.